welcome everybody to the Confronting Stigma in HIV, STI, HIV, HCV Care. My name is Neil Self. I'm the Vice Chair of Positive Living BC. Just a few housekeeping items before we begin. Again, I always like to do this every time I'm up here, is acknowledge that we are on unceded traditional territory, the Coast Salish people, so just keep that in mind. Also, just a reminder, please turn off your phones, because I know you're out on the break and on your phones and everything, so just make sure you turn them off again. And also, I'd just like to remind everybody the format. So we're going to have the presenters speak for about 20 minutes, and then we'll have 5 minutes for questions. I know if I'm presenting, I prefer that format than questions in the middle. And some people don't, and some people do, but personally I like that, because then I can focus on the presentation, get it over, and then I can deal with the questions. So I'd ask you to hold your questions to the end of each present, and then we'll have about a 5-minute session. And I'm really glad that this topic has been covered here today, because I can tell you in the 25 years I've been HIV positive, we've made some remarkable advances, of course, in HIV care. We've gone from a death sentence to a pretty much a life sentence, just on HIV drugs. But the one area that we haven't come that far in, to me, is the stigma around HIV and that. So I'm so glad that this conference is centered around stigma, and in fact, this presentation is around confronting stigma in care. So without any further ado, I'll introduce our first speaker. Our first speaker is Zachary Tanner. He's a recent graduate a very recent graduate of Simon Fraser University Master of Public Health program. He's a research assistant with the BC Centre for Excellence in HIV, and has worked with both Momentum Health Study and the Canadian Observational Cohort collaboration. His research interests include social and structural factors that heighten HIV risk and exacerbate treatment outcomes. Please welcome Zachary Tanner.
Hey, good afternoon, everyone. It's great to be here. Let me just open up my presentation. Okay, so as mentioned, my presentation is titled HIV Treatment Response Among HIV-Positive Gay, Bisexual, and Other Men Who Have Sex with Men in British Columbia, Ontario, and Quebec. And before I begin, I'd like to acknowledge my co-authors and also thank the CBRC for inviting me to speak here today. And how do I proceed? Okay, so many of you likely already know this, but just to make sure we're all on the same page, I'm going to start out by providing a little bit of background and context. So gay, bisexual, and other men who have sex with men have by far the highest prevalence of HIV in Canada. But since the discovery of combination antiretroviral therapy, adherence to this treatment has greatly reduced HIV morbidity, mortality, and HIV transmission, and also greatly improved life expectancy among people living with HIV. Adherence to CART has demonstrated the secondary benefit of reducing HIV transmission through the suppression of HIV RNA to undetectable levels. But despite the proven clinical and preventive benefits of CART, GB-MSM continue to experience a sustained rate of new HIV infections. And this ongoing disproportionate burden of HIV among GB-MSM is attributable to a myriad of behavioral and social factors, including stigma, also as well as insufficient access to gay-friendly health services and distrust of available healthcare providers, which may deter some GB-MSM from seeking testing and ongoing treatment services. And continuation of treatment is crucial for ongoing clinical success and HIV prevention, as incomplete CART adherence can promote episodes of HIV viral rebound. And viral rebound occurs when measured HIV viral loads surpass detectable limits. And viral rebound greatly increases the risk of both onward HIV transmission and can result in treatment failure. And unfortunately, there's currently a gap regarding modern-day CART treatment response among GB-MSM in Canada. And the Public Health Agency of Canada has identified that there is a need to develop a greater understanding of this area, as both viral suppression and any subsequent experience of rebound are important clinical outcomes and have meaningful implications for prevention and long-term health. And furthermore, the UN AIDS has recently announced a plan to end the spread of HIV. The solution, known as 90-90-90, advocates for expanded uptake of HIV testing, linkage to care, and card adherence so that 90% of people living with HIV are diagnosed. The 90% of diagnosed individuals are linked to CART treatment, and that 90% of individuals on CART are virally suppressed. And mathematical modeling suggests that achieving these targets by the year 2020 will enable the world to end the AIDS epidemic by 2030. And so this new UN AIDS objective that 90% of people on CART achieve viral suppression provides a timely and pertinent framework for assessing where Canadian GB-MSM stand with regard to this ambitious treatment target. Also, determining factors associated with suppression and rebound are essential for identifying GB-MSM who are at higher risk of treatment failure and for preventing future HIV incidents, as well as promoting better care for GB-MSM living with HIV. And so the purpose of this study was to identify social demographic and clinical correlates of treatment response among GB-MSM in Canada, as measured by time to viral suppression and time to viral rebound. And we define time to viral suppression as the time to the first of at least 2 consecutive viral load measurements below 50 copies per milliliter, taken at least 30 days apart within the first year of treatment. And similarly, time to viral rebound was defined as the time to the first of at least 2 consecutive viral load measures above 200 copies per milliliter, at least 30 days apart. And this analysis used a retrospective cohort design, meaning that all study events of interest have already taken place. Data from a 12-year time span were analyzed and used to establish different risk factors that were associated with episodes of both suppression and rebound. And participants were drawn from the Canadian HIV Observational Cohort, or CANOC collaboration, which is a pan-provincial cohort of HIV-positive individuals who initiated CART on or after January 1st, 2000. It's comprised of individuals who were 18 years old at baseline. And the participants, the collaboration includes 8 cohorts that represent the 3 most populous provinces in Canada, British Columbia, Ontario, and Quebec. And the cohorts from these provinces provided clinical and laboratory and demographic data. And so we did have to exclude some participants from this analysis. Male participants with missing or unknown GB-MSM status were not included. And I should also mention that GB-MSM, the classification we used, is based on the MSM HIV exposure category that's used for HIV case surveillance and case reporting that is collected at HIV diagnosis. And back to the exclusion criteria, we also had to exclude participants who did not have at least 2 viral load measurements within the first year after initiating CART. And the study timeline was 2000 through 2012, and we used survival analysis to explore the association between covariates in each of the 2 outcomes. And the CANOC collaboration has a large number of demographic and clinical variables available. And for this analysis, we chose to focus on age, the province of residence, ethnicity, whether there was a history of injection drug use. We also examined participant CD4 count, both at baseline and recent, CD4 count being an important indicator of immune response. We also examined viral load, whether participants had an AIDS-defining illness before they initiated CART, also if there was a hepatitis C co-infection, and also the CART drug class that patients began therapy with, as well as their CART start date. And our preliminary results, overall, 2,858 GB-MSM participants were included for the analysis. The median follow-up time was 5 years, and the median participant age, median baseline participant age was 40. In terms of geographic distribution, 30% of participants were from BC, 37% from Ontario, and 34% from Quebec. And approximately 9% of participants had a history of injection drug use. And in terms of the two outcomes of interest, overall, 86% of participants achieved viral suppression in a median time of 5 months. And among these suppressed individuals, approximately 12% experienced a subsequent rebound episode. And the participants who experienced rebound did so in a median after initially being suppressed for 22 months. So they had maintained suppression for almost 2 years on average before experiencing rebound. So in terms of suppression, these results are close to the UNAIDS 90% suppression target. And looking more closely at the different factors that were associated with both suppression and rebound, after adjusting, we found that initiating CART in a more recent calendar year was a significant factor that predicted suppression, with participants who initiated between 2004 and 2007 and 2008 and 2012 having a 26% and 32% increased chance, respectively, of achieving suppression compared to participants who initiated between 2000 and 2003. Also, we found that being older at the start of treatment predicted a greater likelihood of suppression, whereas participants with higher baseline viral loads and injection drug use history had a lower likelihood of achieving suppression. And moving on to the viral rebound model, many of the same correlates predicted better treatment response here as well. Once again, more recent era of CART initiation predicted a lower likelihood of rebound. And in this model, province of residence was a factor. Living in either Ontario or Quebec predicted a lower likelihood of rebound than living in British Columbia. Also, being older at baseline at the start of treatment predicted a lower likelihood of rebound. And having an injection drug use history and having a higher baseline CD4 count also predicted a higher likelihood of rebound. And the observation among injection drug use history is particularly dramatic, with participants who had an injection drug use history had over a 150% greater likelihood of experiencing rebound compared to participants without an injection drug use history after controlling for other factors. And I wanted to delve into some of these covariates in a little bit more detail. So as expected, the timing calendar year of CART initiation influenced both outcome measures. And of course, more effective and better tolerated antiretroviral regimens have been developed in more recent years, which likely contributes to this finding. Also, calendar year itself is a factor simply because individuals who initiated CART in earlier years have simply had more time to experience an episode of viral rebound. And regarding injection drug use history, injected substances can either speed up or slow down the activity of the liver, and optimal liver functioning is important for breaking down ARV drugs. And there's also a higher likelihood of HIV and hepatitis C co-infection among people who inject drugs, which leads to greater morbidity, which could have translated into more episodes of rebound and reduced likelihood of suppression among this population. A few points I wanted to make about age. In general, younger persons are less likely to seek care or adhere to treatment regimens pertaining to HIV or other health issues. And in addition, due to effective treatment that's available now compared to 20 years ago, HIV may no longer be viewed as serious a health risk among younger generations. And younger age has also been previously identified as a marker for poor adherence to HIV drugs, which would also cause viral rebound. And also I want to close up by mentioning the normal developmental trajectory of adolescence and young adulthood involves behavioral experimentation, risk-taking, identity formation, as well as confronting a host of difficult choices. And these conditions may complicate balancing a lifelong ARV regimen and coming to terms with having a chronic and stigmatized disease. And A couple points I wanted to make about the CD4 cell count finding. We did find that overall our participants had a low baseline CD4 cell count of 230 cells per milliliter cubed. And this is concerning because previous research has shown that patients who begin therapy with CD4 cell counts below 250 are at higher risk of AIDS diagnosis. Although I should mention that the clinical guidelines that recommend CART initiation had a lower threshold for much of our study period, recommending that CART initiation begin after patients are at the 250 threshold. But even like over the course of time throughout the study, CD4 count, the average participant CD4 count did increase, but it was always below the recommended threshold. So this does show that earlier engagement in antiretroviral therapy should be a priority. And also another point about CD4 cell count is that we found that it had a predictive value regarding viral rebound, which is opposite from what we expected. And so the way we interpreted it was that some MSM participants who had a higher baseline CD4 count may have experienced comparatively better health compared to participants with lower baseline CD4 cell counts, and this may have influenced them to take a break from medication, which may have resulted in an episode of viral rebound. And going forward, it is important to examine this issue more closely because recommendations for initiating CART immediately, regardless of CD4 cell count, emerged after our period of study, first in 2013 for select populations, and then in 2015 with the START trial for all people living with HIV, regardless of what their CD4 cell count is. So as such, the proportion of HIV-positive patients initiating therapy with higher CD4 cell counts will increase going into the future, which will provide an opportunity to obtain a better understanding of this issue. And finally, I want to mention the finding we had regarding province and its predictive value on viral rebound. I should note that the sampling frame for BC participants in CANOC is different than that for the Ontario and Quebec cohorts. Participants from BC include all individuals on antiretroviral for the entire province, as this data is linked through the BC Centre for Excellence in HIV's drug treatment program, which distributes antiretrovirals to all people living with HIV in British Columbia. However, the Ontario and Quebec cohorts in these provinces, antiretroviral distribution is not done through a single centralized program. And as a result, the Ontario and Quebec-based CANOC participants are all clinic-based. And this provincial difference in participant selection likely creates a bias that results in the Ontario and Quebec patients being healthier than the BC participants. And this may partially explain the provincial difference regarding rebound outcomes. And moving on towards the recommendations, efforts should be focused on GBMSM youth and GBMSM who use injection drugs, as these subpopulations demonstrated highly reduced likelihood of achieving optimal treatment response. Unfortunately, there is a scarcity of research and evaluation work that is specific to GBMSM youth with regard to HIV care engagement strategies. But the most encouraging interventions for improving retention and care and CART adherence among the broader population of HIV-positive youths involve self-monitoring, peer support, telephone follow-up, and ongoing caregiver education. And for GBMSM who inject drugs and other vulnerable people living with HIV, more intensive case management and outreach services have a strong record of improving health outcomes among HIV-positive patients. Also, focusing on psychosocial supports is a necessary strategy for reducing treatment disparities. For example, housing interventions and strength-based peer navigation services have been shown to improve HIV treatment self-efficacy. And closing things out, I wanted to go over some of the strengths and limitations of this analysis. First of all, we had a very large sample size. CANOC represents the largest cohort of HIV-positive individuals in Canada, and is comprised of an estimated almost 50% of HIV-positive individuals on antiretroviral therapy. So this helps improve the generalizability of our study findings. Also, the longitudinal nature of our study allowed us to examine temporal trends in HIV viral suppression and subsequent rebound. And this is important because a considerable amount of HIV treatment response research is limited to surveillance data and cross-sectional analyses, which is, of course, more restricted in its capacity to make inferences over time. And as I mentioned earlier, there was the clinic-based selection bias issue regarding the cohorts in Ontario and Quebec. And we also had to exclude over 2,000 individuals from the analysis because of missing or unknown GB-MSM status. And also, we only had history of injection drug use available. We weren't able to speak to ongoing or current drug use or frequency of drug use. And in conclusion, the study represents the first longitudinal pan-provincial analysis of HIV treatment response among GB-MSM in Canada. And we found that the large majority of this population on CART is quickly and successfully achieving and maintaining viral suppression. And also, the Canadian GB-MSM on CART sampled for this analysis are within reach of the UNAIDS proposed 90% suppression target. But to better realize this target, further strategies are required to optimize CART outcomes, specifically targeting younger GB-MSM and those with a history of injection drug use. And that brings me to a close. I'd like to thank all my co-authors and all the CANOC collaborators and the CBRC for inviting me to present this today. Thanks.